All right, in our last video here, we're going to discuss hip fractures, amputations, osteoporosis, and osteoarthritis. So hip fractures are some of the more common fractures that we're going to see, especially when it comes to the elderly. The classic signs and symptoms of hip fracture, besides, just pain at the area, is they'll have an external rotation and shortening of the leg. So the leg becomes shorter than the other one, and an external rotation means that the foot kind of falls out to the side. For treating a hip fracture, we want to immobilize the injury as much as possible, and so we don't want the patient rolling around or getting up in bed too much. Generally, sitting up in bed can be too much pressure that we're putting on the hip as well. But again, you're going to talk to your patients and see what's most comfortable for them. This is also a great time when we want to use those pure wicks. So if the patient does have to pee, they don't have to be getting up or moving. Ultimately, to treat the fracture, they are going to need surgery. But some of our patients can be not a good candidate for surgeries. And so that's why sometimes in long-term care facilities, we'll just have unhealed hip fracture patients that are kind of sitting there because they're not stable enough or safe enough for surgeries. And then they can't take care of themselves at home anymore. The big nursing implications are, like I talked about, we want to use that pure wick so that they're not moving. We want to make sure the patient's in a comfortable position. We want to get some pain management on board, so we're giving them some medications that help. And then the other thing is, the important part is educating our patients, especially if they have had surgery. And so if they have had surgery on the hip, then there's a lot of patient teaching that goes into it. And it generally involves not flexing that hip. And so the patient shouldn't cross their legs. They don't want to flex that hip greater than 90 degrees. They don't want to adduct the hip or internally rotate the hip. And so there's like adaptive devices they can get for putting on their shoes so that they're not bending forward too much and flexing that hip too much. There's like seat raisers that they can use on their toilets. So again, they're not sitting too deep and flexing that hip too much. They want to use chairs with arms, that sort of thing, to again help them sit up. And so the other part of patient education is, since not all of our patients are candidate for surgeries, we want to help prevent falls as much as we can. And so we want to educate our patients, especially our elderly patients, on how they can prevent falls at home. So no rugs at all. We want to get cords out of the way. Keep their environment consistent. They can use the life alert buttons. Comfortable shoes are a huge thing too, to help with our fall patients, to make sure that their feet are comfy and not going to be tripping over something because they're not feeling stuff. So some of those injury prevention, fall prevention strategies are great to know for our patients as well. All right, so we're going to talk about amputations. We have been seeing these more and more. There's been a very big increase in amputations because there's been a big increase in diabetes in our society in general, and then there was also the delay of care for patients not seeking treatment during the pandemic. And so it could also be from peripheral vascular disease or neuropathy that leads to untreated wounds. It could be a trauma amputation that happens in our younger patients, like motorcycle accidents, motor vehicle accidents. And then it could happen from battle injuries too, so our veterans are another population we watch out for. When it comes to amputations, we really need to be watching our patients out for a few things. So disturbed body image is a huge one. Impaired tissue integrity, impaired physical mobility because we're taking stuff away from them, and then chronic pain tends to be an issue too. So our goal with an amputation is to keep as much length and function in the limb as possible. There's an interdisciplinary team approach to this. So we've got counseling services, physical therapy to maintain function, occupational therapy to help them at home, with things that they might have to adjust, case management to help make sure that the home is safe. There's a lot of team members involved before an amputation takes place. And then that chronic pain symptoms generally comes from this phantom limb sensation. So if that's happening acutely, if that's happening within the first few days after surgery, we are treating it as acute pain. But as that becomes a more chronic problem, if it's months after surgery that we're having that, there are different treatments that we will use to help prevent sort of our patients getting addicted to those controlled substances. So with amputations, we try and get a prosthetic onto that amputated limb, but it's a delayed prosthetic fitting. Usually takes about 3 months for that residual limb to shrink. So they'll use compression bandages at the very get-go to compress that limb down. And we want to apply it snugly, but not so tight that it cuts off circulation. And then the patients, after the ACE bandages, so after the initial acute bandage for surgery, then they'll move to these elastic stockings to help shrink that residual limb. We want to reduce edema, which helps improve the healing and the pain. And then we also want to teach our patients to avoid dangling that residual limb whenever possible to help reduce edema. Another big thing when it comes to amputations is these patients need to have the residual limb stretched. So like if it is a leg amputation that we're talking about here, these patients cannot be sitting for long periods of time. They have to be put into the prone position, so on their belly to stretch that hip flexor out. Otherwise, that hip flexor can get too short and kind of contract, and they can get a contracture from it. So these patients, we want to not elevate the limb. We can after like the first 24 hours after surgery, usually they'll elevate the limb to help with edema. But after that, we really don't want to encourage that hip flexion at all. So it's more about just keeping them flat and laying them on their belly to kind of stretch that limb out. Osteoporosis is a huge one that we see in our patients because as we get older, this is just what happens. So we have decreased bone density with age. There are multiple risk factors that contribute to this. Table 63.12 in your book lists out those risk factors, and I would be familiar with those for your exam. This is more common in women, and again, it relates to those risk factors. So it's got something to do with the hormones and everything that can definitely decrease that bone density. And then when our bones are less dense, the patients are at more risk for an injury if they fall. So fracturing that hip is more likely to happen if it's osteoporotic bone as opposed to a normal healthy bone. And so, like I said, there's that table that talks about the risk factors, but bone density is usually related to 4 factors. So there's a heredity aspect to it, or a genetic aspect. There's nutrition aspect to it, exercise, and then hormone function. And so bone loss is inevitable as we get older. It's just going to happen, but we can decrease the rate of that loss by helping to impact these factors. So menopause in women and low testosterone in men are huge risk factors. And so we can try and accomplish some of these other things through nutrition and exercise to help combat those other factors that we may not have control over. Weight-bearing exercise is great. Walking, it doesn't have to be intense weight-bearing activity. Walking is still weight-bearing, right? You're still bearing your weight. Another good one is strength training. Again, these guys don't have to be, going and doing huge deadlifts and huge squats, but just getting into the gym and training with weights really helps with that, increasing that bone density for these patients. Nutrition, we want to make sure they're having the proper nutrients so that they're now not malnourished. And then we also want to make sure that they're having calcium and vitamin D supplements. And so Some foods high in calcium. We've got dairy, we've got leafy vegetables, that sort of thing. And so we really do want to watch our vegan patients and our patients with lactose intolerance or dairy intolerance who could be at risk for some a low calcium diet. And we really want to get them on calcium supplements and vitamin D supplements. Osteoarthritis is not a normal part of the aging process, unlike osteoporosis. So this is a disorder of the joints, and it's non-inflammatory. So generally, osteoarthritis is usually compared to rheumatoid arthritis. So rheumatoid arthritis is an inflammatory disorder, whereas osteoarthritis is non-inflammatory. It generally happens from a gradual loss of the cartilage or causes a gradual loss of the cartilage. Patients can form these bony spurs or outgrowths onto their bones that cause pain and kind of catch along each other. Aging is a risk factor, even though it's not a normal process of the aging process. And so our symptoms of osteoarthritis is joint pain. And it's usually on one side as opposed to both sides because, again, that asymmetrical aspect. Whereas since rheumatoid arthritis is just an inflammatory disorder, that one's bilateral or systematic. They can get this crepitation, which is this kind of grating sensation, that kind of crunching sensation in the joints. It's usually from loose cartilage particles in the joint cavity. Pain gets worse with activity, and then stiffness gets worse with inactivity. So these patients are playing a bit of a balancing act. They can't just lay there because then they get stiff, but they can't get out and move the whole day because then they have pain with the activity. And so they generally get this early morning stiffness because they've been laying in bed, but that resolves within the first half hour or so of the day, as long as they get up and start doing some gentle movements. And like I said, they have this pain in their joints, or just one joint. It depends on the patient. And it can be anywhere from mild discomfort to severe disability. So these patients might be on different treatments depending on what sort of symptoms they have. And so some of the symptoms, or some of the treatments that we use is, like I said, balancing that rest and activity. They can't just stay still because then they're going to get stiff. And they can't move all day because then they're going to get too painful from all that movement. And so that immobilization can lead to an increase in the stiffness. They can use ice packs to help with like an acute inflammation, an acute exacerbation of their arthritis. Whereas heat tends to help more with the stiffness. We want to encourage these patients to lose weight if they are overweight, because again, it's just less stress on the joint. And we do want to encourage them to do some range of motion exercises. So even if that knee or that elbow or that finger is bothering them, we still want them to be encouraged to keep range of motion as much as possible. So we can do passive range of motion, or they can do gentle active range of motion as well. These patients tend to benefit from some of our alternative therapies like acupuncture, tai chi, massage, yoga, that sort of thing. We want to help them find some safe therapies, of course, especially if stuff that they've been taking from us hasn't been working. When it comes to pain medication for these patients, they are not on narcotics. This is a chronic, long-standing issue, and narcotics are not going to be helpful. They're just going to cause side effects and not really help the patient long-term. So these patients were generally using Tylenol or NSAIDs. So ibuprofen, Aleve, whatever their favorite one is. They can also be on steroids, whether it's an oral course of steroids to help with an acute inflammation, or they can get steroid injections into the joint too that helps with inflammation. They can also use some local anesthetics, so like lidocaine patches, lidocaine cream. They also have an NSAID cream out now where they can just locally put that anti-inflammatory on whatever joint's bothering them instead of taking something by stomach. This is helpful for our patients that have some of the GI upset from taking ibuprofen or Aleve. They can just use the ointment on the joint itself. Another one that's coming out more and more in the research is capsaicin cream. So like that spicy oil that's found in peppers. They have it in a cream and it helps block pain impulses to that area. So that they get this kind of burning, tingling sensation, but it helps block the actual pain. So capsaicin cream also helps these patients. All right, that's all I've got for musculoskeletal. I'll see you guys in class so that we can start applying this information.